Thanks, everybody. I come before you because within my role, that lovely long title that Trevor read out, that's maybe descriptive and maybe not descriptive, I have medical governance and medical audit within there, and that's about establishing systems to enable both of those things to happen. So that's how I come to be before you today, apart from the fact I work pretty closely with Barry to get, and Colin before him, to get FASM up and going at Epworth and then more broadly. As I set off down the topic of this quality monitoring in the private hospital setting, I thought, let's try and find how the private sector is different. And so I looked for things, I found a couple of little things, but more broadly I suddenly found that it's not so different between the two sectors. And having stood and listened to everything that's been said today, excuse me, my mind isn't changed at all. Everything was described through the morning, and in fact just listening to Neil talk then about how do we define unexpected, that's a journey I have every single day. We've tried to drift away from the word unexpected towards potentially avoidable or unavoidable. So it's, this story I was going to tell you about how different, I'm going to bore you a little bit because it's actually not so different. So I'm going to focus a little bit upon some of the differences, the challenges we face as a result of those differences, and then some of the solutions we've put in place. I'm not now talking on behalf of the entire sector. This is a bit of an Epworth experience. So Epworth, just to give a bit of a story, I'll quickly whip over this one. Really the message in this, it is pretty big, it's complex. We've got everything from an 18-bed hospital in East Melbourne all the way through to the several hundred-bed hospital at Richmond, 8 different locations. There's a new one going up in Geelong that'll be open in the middle of the year. It's tricky, it's complex. We pretty much get everything except aged care. We go all the way from babies through to rehab. Largely visiting specialists. We have a few employed within the rehabilitation emergency areas and intensive care, but there are, I guess, those team-based areas. That's just to give you a sense of where we're at the moment. 2,500 doctors on the books. Large portion of those are surgical assistants as opposed to pure admitting specialists, but it's a big setting, 4,500 staff. It's a big picture thing, so I can play with the little hospital thing where you've got that relationship in the little hospital where you know everybody, through to the big hospital where you only know the people you deal with regularly. Yes. Right, excellent. So this is where I went into the little comparison piece. Now the national standards, we've got those 10 and the 5 or the 10 that are going to follow. That's the same. There's nothing special here. We're the same as everybody else. The trick is linking hospital standards and their relevance, and I'm seeing that more and more coming. Health funds, that's our primary payer as opposed to a health department. So that's our relationship we'll talk a little bit more about, and I guess you've all read the newspapers to know that's an interesting relationship that's growing and changing in the way it works. Largely visiting specialists, so that's the different relationship. We don't have that employee basis for the way we work with our specialists. Same information sources. We've got coded information. We use MBS, we use DRGs, we work with registries. It's the same information. So the challenges. I started 6.5 years ago, and I originally then had the role to establish systems around clinical audit and less around the broader medical governance. The question immediately was, who owns the patient? Well, it's my patient. I brought the patient to you to operate on them. You just take care of them and then I'll take them away and they'll be mine. Well, we've got a real responsibility here. We're caring for this patient, we're providing facilities. So that was an interesting tension that I've really seen drift across the time. It is now a shared relationship. Who's the customer? Well, I can tell you, I think 10 years ago, very clearly, it was the doctor was customer. The doctor brings the patient, we take care of the doctor and everything will be fine. There's been a massive shift now. It's very much patient and doctor as customer. Try and take care of both groups. And I've deliberately used the word customer to deal with that consumer discussion we had earlier today. I think there's a customer mindset here. Who are we working with? Well, both groups. There's a patient experience. Those words have entered our sector as well, whereas historically that would have been a solely public sector bit of wording. I've left the dots there in that third point. By what do you examine the care I'm providing? I'll provide what care I provide. I've come here. Now this is words I've heard. It's very much the minority that we're hearing, but these are things that exist. These are some of the challenges to be faced. How dare you, I'll provide the care I see. I'm a fellow of the college. I've done my specialty training. I'm an expert. Leave me alone. I'll provide my care. And then we've got the health funds as a challenge. Now they've just gone from providing us money to provide not too many events of care, to suddenly moving from that volume over to a value sort of argument. At least that's how it's being put. And the care that we're providing together, that is we, hospitals and all parts of hospital, is now being examined for how well that care aligns with guidelines. Now, the guidelines have yet to be defined, so that's the next bit of the journey we're going down, but this is a really big shift in the way we start looking at that whole quality control, quality monitoring. We have a new player in that room that are starting to ask questions that they haven't before asked. So that's just a new dynamic that's, one of the challenges we face. Probably not a bad thing to start thinking about the outcome and the like. Let's move towards that as our real focus, but it's very much a different focus. So now we'll move on to the solutions, which is a bit about where we got to. I'm going to talk a bit about principles at a high level and then some of the things we've done. Without delving into too much detail, we can do that in questions if we like, but I'll try and cover off on the key points. I think the first thing we've got to do is that whole part, is the relationship thing, is to establish trust. We're not here about a witch hunt. We're trying to put systems in place to know that we together are providing good care to the patients. The patients are getting the right care, the right resources exist, the right processes exist, and then we're giving the right care. It's not about, I want to prove to you that you're worse than everybody else. The league tables conversation comes up. It's not about that. It's about working together to deliver right care. It's getting routine together. Let's have something that's clear and predictable so that when it's put up, well, everyone else is part of this. That specialty's doing it, but my specialty isn't it. Why aren't we? Or everybody else in my craft group is doing it. Why am I not? Let's get systems. Let's just make them routine. Get the robust information, and I'm going to stop at that before I get to the processes. Data integrity, we're no different in that when you try and compare somebody, they'll tell you, first of all, your data's wrong, and then when you prove that the data is right, or at least you know how wrong it is, well, you can't compare me because I'm different. So we've got to get robust information in place so that we can have a conversation without that piece of it. Now, I've produced things that were absolutely wrong, there's no question. I produced a report on deaths in our rehabilitation sites that sent the Director of Rehabilitation running back at 8 o'clock at night to find out who all these deaths were. This was very early in my stay, and I do a little bit of mea culpa here. I released something that I thought to be correct, and what it was deaths of patients who had been to rehabilitation, and it happened to relate to future contacts with patients. Someone might have died in the community. We heard about it because the GP wrote to it. There was a field in one of my reporting systems that said, patient is dead. Might have died 10 years after leaving the hospital, might have died the day after, might have been in hospital, but I can tell you he got a terrible shock when, his 2 deaths a year that occurred on site in the rehabilitation beds suddenly appeared to be about 3 a month. These were just people that happened to have died. So I've got to get it right and then own up to it. And I think you've got to be willing in those robust information processes to have the conversation when things don't appear to be right. There'll be people in this room that know we've released things that didn't look right, but we released them with things. So look, we want to work with you to get it right. And that's all about coming back to the trust. So we think it's right. This is what we think. Is it consistent with what you think? And that might be just down to counts of patients. And there's any number of inconsistent approaches to the way you count things, particularly when you use MBS item numbers. The one I decided is the most important is different to the one you decide is the most important because of the way you perceive the procedure. Write down what it is so that everyone knows what you're dealing with, so that this is just simple quality improvement, so that we all know what we're discussing. Write it down and then say, this is what I'm going to do. Is this what you agree that I'm going to do? So write it down, then the conversation's easier. Do you remember we talked about that 2 years ago? Yes, but I don't agree with it now. Okay, well, let's consider what that means. You've got to come both carrot and stick. We've got to have a conversation. This is, can you please participate as well as you must participate? This is, allocating CME points as part of audit processes. This is writing it up in the bylaws, which I'll talk about in a little bit more detail in a moment. It's requiring participation, but spelling out what participation means. Make it easy. Let's get the information out there simply. Don't require too much burden. People have enough things to do without having to write things down and add double count and double enter and go and find things. If possible, let's give it out. And this is all a journey I'm on. I'm not saying we've fixed all of this, but this is absolutely where we're off to. And then the last thing is ask, because it's got to be clinical relevant. What would be useful to you to interpret the care we together are providing the patients? Now we'll get into a little bit more detail. In the middle of last year, we went live with the new set of bylaws for Epworth. This took 18 months worth of consultation, legal review, broad specialist consultation. Had to go all the way through the board. We'd had a full appointment process. We'd moved from accreditation to appointment. But in doing this, we've spelled out more clearly what the requirement is. Now, in short, what that says, as part of your appointment as a practitioner at Epworth, you must participate in audit or in terms of or practice review, whatever that might be. You must participate in whichever registry is deemed by your craft group leadership, which we'll talk about in a moment, has deemed to be the requirement. And this is the first step, is writing it down. The next bit is actually bringing out the stick and saying, hey, you've got to actually do this. We've first of all got to say what it is, make it easy, establish trust around the process, and then say, you've got to do it. So they're the words directly from the bylaws, which are available on the internet. That's in part of an extensive list of requirements that go down, I think, to II or something or other. One of the approaches we've taken is to look for apparent complications, deliberately use the apparent, because something that has happened, a return to theatre might be a trivial staged procedure, but it's listed as a return to theatre because we haven't quite worked out what expected and unexpected is. It's looking for things that are listed as wound infection, and as we know, that the health information code for wound infection can mean a little bit of reddening around some sutures and some Keflex through to a full deep organ space injury. Same code, so we've got to start with what it is and let's work out how apparent it is. Let's look into themes, let's look into new techniques and see how they work. Let's compare a technique to another technique. And then let's actually get into the exploratory discussion, but let's try and make it routine where we look for the same things consistently so that there's transparency around the process. Tailor it for the clinical group. Let's get information that means something. Right at the moment I'm going through a process where we're trying to craft, instead of counting how many MBS item numbers we do, how many procedures that use words that actually describe what the craft group cares about. Because if I report up numbers, they go, well, that's not what it means to me. So let's try and tailor what we're doing to the audience. Information sharing, part of my role is just making sure the information flows out. I remember, so I come from an intensive care nursing background. I left there and went to another job and suddenly saw all this information. I saw reports from intensive care registries, cardiac surgery registries. I said, gee, that's my background. Where did all that information go? Why didn't I see it? I would have loved to see that. And I keep reminding myself, 10 years down the track, get it out to the people who can do something about it, who care about it. That improves your data entry, and it improves their knowledge of what they're doing, and it gives you a chance to go, gee, look, we look pretty good, don't we? So it's about, I try and spread the word off the director's desk out to the people involved in that group. Now I'm just going to have a look at how we tailor clinically at Epworth. We've established these things back in 2009 called clinical institutes, where we bring together groups, not under surgery and medicine, it's a bit under body type. So cardiology, cardiac surgery sit under cardiac sciences. Neuroscience clusters together neurosurgery, orthopaedic, spinal and neurology together. So it's that sort of approach. Their roles are listed there, and at the top there I've put audit and peer review because that's the bit I really, really care about, and there's a lot of delivery in that. The second line is around advancing, because we have education and research components to Epworth that we have to work with rather than deliver. And then there's the review of scope of clinical practice, competence and all those sorts of things which are conducted by this group. Sorry, I've skipped a slide there. They are overseen by an executive committee. This is the group that helps, that I go to and say, here's what I want to do in relation to audit. Do you endorse this approach? And that's where we have that conversation. They are each at different levels of development. And where there are external groups such as the Cardiac Surgery Registry, the Cardiology Registry in Victoria, that's pretty easy. When something's externally valid, trusted by the sector, it's easy to go, we should do this and get it happening. When we've got to create it internally, there's a lot more buy-in, because you then get into what's the right approach to take. So I said at the start that the conversation was, I thought I'd go and find lots of differences and found a lot of the sameness. I think the message is we've got the same responsibility to the patient. It's just the how we go about it is slightly different, but the what is no different whatsoever. We've got to, we have to go and take care of what the end point is. What care are we providing? How do we do it? Nothing I heard today was any different to the experience I've got, except for the fact we're all in Melbourne and not in regional centres. And I think that's really, let's work together and make it clinically relevant and make it just part of every day. This is not that special thing that hangs out on the side there. So thank you very much for your attention.